Hello, and welcome to the Transformed Minds. I am so happy you're here today. This is the podcast where we explore the real world intersection of mental health, addiction, and transformative care. And I'm your host, Dr. O. With each episode, we take a thoughtful, practical, and evidence-informed look at how we can improve psychiatric and addiction care from our clinical settings to our community spaces. And if you're new here is the vibe. We always have a expert RX where we bring in brilliant minds across the field, whether you are a clinician, a physician, a researcher, policymaker, advocate. We bring you here and you share your expertise with us. We also have our Live RX. This is where the real life stories come in. Guests who have lived it, they have survived it, they are experts, and they are reshaping the systems because of it. And we have what today we are going to do together, our host RX, where it's just me and you, and we just break down the literature and see what actually matters for the work that we're doing. I am glad that you're here. I also want you to remember, as always, this is for educational purposes only. It's not clinical advice. Addiction treatment is something that does not just depend on who needs the care. We have come to find out that it also depends on your insurance status, where you live, who you are, where you're from. It depends on a lot more things than just the treatment that the person needs. The system has been built that way, or has been built in a way where it's not doing what it has to do. And the evidence is very clear. Access to medication for opioid use disorder can actually decrease mortality by half, like literally 50%. But access itself has been unevenly distributed across the span of race, ethnicity, socioeconomic statuses. The opioid crisis has claimed like more than 1 million lives in the US alone over the past 2 decades. Yet, we know that effective treatment exists, particularly, like I said, medications for opioid use disorder, like buprenorphine. The research is increasingly showing that the greatest barrier isn't just the science, but it's really access. If you listen to a lot of episodes, we tackle access over and over again because it's a huge barrier, and the research shows that. So a landmark study from 2019 in JAMA Psychiatry actually found that buprenorphine treatment was disproportionately prescribed in predominantly white and higher income communities. Even though we all know that the overdose burden is often elsewhere. They're mostly in marginalized communities, people of color, but the treatment is in different places. A 2022 study in JAMA Network actually demonstrated that policy and structural factors, not just clinician availability, is shaping who's receiving that care. So when you think about the care that's happening in higher income communities and or more Caucasian, it's not because there's a clinician shortage, it's because the system has been built that way. Another study also emphasized that disparities in access reflect the broader structural inequities and is embedded within our healthcare systems. So we see that these findings are actually challenging the narrative that addiction treatment gaps are simply because the people that are experiencing these disorders or misuse are not motivated, or there's not enough clinicians. And this is not to take away from the fact that, yes, there are not enough clinicians doing this, right? But there's a bigger systemic pattern that's shaping the care that we're delivering. And I want us to be able to talk about that, address that. The treatment disparities are not accidents. They're actually predictable results of policies that have been made, decisions that have been made. It's a system-wide thing. So to begin, let's think about, what does the research actually tells us about access to addiction treatment in the United States? The literature over the past decade has fundamentally reshaped how we understand addiction treatment and access. One of the key findings from a study by Legisetti and his colleagues in 2019 in JAMA Psychiatry, which I was referring to earlier, showed that buprenorphine primarily actually is prescribed more in white people and in people that make more money, even though the overdose rates are more in diverse and economically challenged neighborhoods. So this kind of shows inequities that happens. So what's missing? There's a misalignment of who needs the care and who's receiving the care. according to the literature. One of the studies from JAMA as well in 2022 shows that policy and structural factors are playing a role here. It's not just clinician availability, because most of the time, unfortunately, the blame of why there's these gaps have gone to, oh, there's not a lot of clinicians that are taking care of the problem. Yes, that's true. We need more clinicians. We need more people to go into addiction. It can be complex at times, and it's not a lot of people currently doing it, but it's such a rewarding career, something that obviously I'm passionate about because I'm doing this. I'm trying to educate people. But I also want to use this moment as a call to action for anyone that's interested in psychiatry, interested in addiction, whether you want to be a peer advocate, you want to be a therapist, you want to be some form of counselor, you want to be the addiction specialist, there are opportunities for you. You are a community organization that want to be a part of closing that gap of how many people or how many providers, caregivers, physicians, scientists we have in the field. Go for it. All right, there's so many open doors. And if you want to connect with me. If you're a trainee, you're a medical student, you're interested, this is my call to action. Connect with me and we will find something for you. We will work on it together. But back to what we're discussing, right? It's not just the clinician availability, but there are policies that are in place and there are structural factors that are playing a role in who's getting the care, which misaligns with who actually needs the care. Another 2023 study in The Lancet also emphasized that disparities in access actually reflect structural inequities, right? So what we're seeing is there's multiple studies that are confirming it's not just the clinician shortage. And even when you think about clinician shortage, that can be from a structural thing. That could be from a policy standpoint. Because you think about how many spots we have for residency. So how many psychiatry residency spots we have, how many family medicine spots we have, how many internal medicine spots we have, right? And what percent of that is going into fellowships? How many fellowship spots do we have for addiction trained specialists, right? You think of who makes that decision of how many spots are open for psychiatrists or internists or family medicine docs, who most of the time, these are people that are ending up going on to do addiction medicine fellowship or specialize in addiction psychiatry to take care of people that need this kind of care. Congress makes that. The people sitting in Congress, they make those decisions. And recently, I think for decades, they just recently, within the last few years, just increased the number of residency spots. There's so many people available that want to do the job, but they don't get a spot to train to do the job. So even when you look at the clinician shortage, you could still trace it back to policies, right? You could think about how much people have to pay to go to school and how many people can afford to do that. Not a lot of people can afford to pay hundreds and thousands of dollars to go to school or to get that education to then come care for the people. Who decides like how much we have to pay for school? Who decides who gets what financial aid or what assistance? All of this comes back again to the people that we're voting for, the people that we're putting in power that makes these decisions. So even when you think about the one corporate that we're blaming for this issue, it still comes back to a structural and systemic policy issue, right? That's the problem that we have. This is why we need advocates, right? People that are on the Hill advocating for more and more support in what we're doing. What this reviews instead is the systemic patterns that are shaping the care. So the treatment disparities we're seeing, they're not just accidents, they're predictable. A few weeks ago, a lot of programs were scrambling, trying to figure out where and what other places they can find funding to do what they were doing, to give the care they were given, to give training because of policies that were put into place. A lot of people had to go into advocacy mode, messaging, calling your representative, sending an email or letter to your senator to vote for policies for funds to be put in place. So it's sad, but these are things that we have to continue to discuss and talk about to make a change. In 2022, another study showed that the policy and regulatory environments had strongly influenced the treatment access. For example, states with fewer regulatory barriers and more supportive policies had more access for people. In American Journal of Psychiatry, another study had highlighted that the importance of structural determinants, including like geographic access and healthcare system design, was important. Another critical dimension to like youth access has showed that adolescents are actually facing even greater barriers, including stigma, limited pediatric prescribers, and regulatory restrictions. And we saw that when we think about policies, like in 2022, when there were changes in telehealth expansion during COVID, more people had access. There were like policy flexibility, especially people in rural areas that did not have a lot of clinicians, doctors, specialists that can help them. They had counselors, therapists. They had that access because of telehealth. They were able to connect regardless of the distance. Back to policy. Policy makes such a great difference. So let's think about if we were to conceptualize all of this, what is going on? When you think about what are the frameworks that are guiding what we're doing, you have to think about structural and mental determinants of health. You have to think about the healthcare system design and policy barriers. You have to think about trauma-informed models of addiction, vulnerability, and recovery, right? Addiction is not just a biological condition. It's deeply shaped by social and structural factors. We know this. There are times where I would say like addiction is not just behavioral, but even when I'm explaining the biological part, I'm also saying addiction is not just biological, right? There is social and structural factors that influence who may pick up a bottle of beer, who may pick up a cigarette and never turn back. I want to slow down and unpack the evidence a little bit more deeply, right? Because we're not just asking who gets treatment. We're also asking why the system is distributing the treatment the way it does, right? What we've discussed already sort of raises critical questions. One, what does it mean when access to office-based treatment grows in some communities but not others? So when buprenorphine is delivered in private office settings in suburban areas but not concentrated in like a highly regulated clinics in urban, historically marginalized neighborhood, we're not just like observing a clinical trend. This is structural stratification of care, right? Office-based buprenorphine really most of the time means like flexible scheduling, integration to a primary care setting, less visible stigma. Methadone clinic-based care often involves daily attendance requirements, transportation burdens, increased surveillance. The science is not different. The delivery model is. One community is going through flexibility and access to even primary care. They get to pick up their medications from the pharmacy and go home. Others have to go and pick it up from the methadone clinic. If you remember one of our past episodes where we discussed how just that whole model of delivery of methadone feels so incarceral. Like you go, someone gives you the pill in the morning, you go back, you come the next day. If you're able to show that, hey, I'm gonna take it appropriately and not misuse it, you may get to take a week's worth or maybe a month's worth home. But that's not the story for everyone, right? Why do some people get the flexibility of taking the medication with less stigma, go home, have a primary care integration, while others have increased surveillance? The science is really not different of what we're giving them, medication-assisted treatment, but the delivery model is different. And mostly, when you look at the population receiving which delivery model, it emulates what the studies are showing. More people with more access are in white, suburban, high-income communities versus racially diverse, living below the poverty line, marginalized communities. It's not fair. But how do policies shape these patterns. What state-level regulatory environment significantly influence buprenorphine access, right? There's states that have reduced regulatory burden versus others that have more. I know, like recently, probably in the last few weeks, the American Psychiatric Association for a while have been lobbying to get an extension on some of the policies that went into the COVID era, allowing more like telehealth, flexibilities, and all of that, because it was actually helpful. And it was coming to an end, so a group of physicians had to go lobby and say, hey, these are the outcomes. Like, we're seeing more people getting more access, positive outcomes for people. So this is something that we need to continue. But if they didn't do that, this was going to be taken away. Policy is not background noise. It's actually like an active determinant of mortality. Because we're seeing pandemic era telehealth flexibility actually led to measurable increase in treatment, initiation, and retention. Like, more people actually started treatment and stayed in treatment because they had access and the flexibility of doing a hybrid system if they wanted to, right? But what about geography? Like, there is an actual MOUD distribution of prescribers. If treatment requires a 90-mile travel, that's not accessible. Like, if I have to travel that far to get treatment, that's not accessible, right? When you think about youth, right, there's not enough child addiction experts that are well versed in treating youth, but also treating addiction. Like, we need more of that specialty care. Because there's that limitation, we know that if we intervene early, it could be protective for people. I recently did a secondary analysis of a SAMHSA data, and it was looking at age of first use and a lot of different socioeconomic factors and the bidirectionality of it. Like, is the fact that I'm living in a lower income community more likely to make me engage in substance misuse, and vice versa? Because that I'm misusing substance doesn't mean that I'm not gonna make more money, because I'm not gonna get a better job because of that, right? Or that I'm gonna end up homeless because of that. So that bidirectionality of it. But what that data also showed was that the earlier you started using substances, the earlier that you had all these socioeconomic problems. And the other way around, the earlier, and we could go back to ACEs with this, right? All you need is 2 ACEs, and you're already like high risk of having a mental health problem. So just having a family member that's incarcerated, living in a community that's below the poverty line, secondary or primary abuse, child neglect, any of these things, right? You just need 2. And it's very easy to get 2 of that, because majority of the country is living paycheck to paycheck or below the poverty line. So it's very easy to get those 2, and you're at a higher risk of a mental health disorder. So what does the psychiatric literature actually says? All of this is saying is disparities in mental health and addiction care are predictable outcomes of structural inequalities that have been embedded in our healthcare system, financing, regulation, delivery methods, and they persist because the system has been unevenly designed. So when you ask, why isn't everyone receiving evidence-based treatment? The literature gives us a very clear answer: because access is structured, not random. And structured systems can be redesigned. And this is where I'm going with it. That we can restructure and redesign what we already have. What do these studies reveal about the relationship between structural inequality and treatment access? The studies that we've discussed show that treatment availability mirrors a structural privilege. Communities with more resources have more providers, fewer regulatory barriers, because they got money, right? They're able to get the things they need in their community, compared to the people that have no voice and no one to speak for them. So what role does trauma really play in addiction and treatment engagement? We know that trauma influences neurobiology, behavior, trust in healthcare system, and it can truly affect treatment initiation and retention. Racial disparities persist even when effective treatments exist. And it really just brings us back to the system design. The system has been designed to systematically oppress people of color. So what policy changes can improve access? Prescribing restrictions, expanding telehealth, telehealth integrated addiction into primary care settings. It can literally greatly help with access. Like, how should policymakers think about addiction treatment as essential health care and not a specialty care? Like, it's needed. We need more people. We need more resources. We need more funding. Like, policy change works, but we literally have to start from the ground up. Let's talk about a case. We have Marcus, who's a 24-year-old. He lives in a rural county with rising overdose. He has Medicaid. He has some childhood trauma, inconsistent housing. He wants help for opioid use after a non-fatal overdose. The nearest buprenorphine provider is 85 miles away. That's far. The local clinic offers methadone, but transportation requires daily travel. See, he needs to go every day. Does he even have money to pay every day for transportation? So from a DSM-5 perspective, Marcus meets criteria for opioid use disorder. So we know that there are evidence-based options available for him. He has methadone in his local community, buprenorphine 85 miles away. We also know extended release naltrexone can also help, right? The research consistently demonstrates that these medications can actually reduce mortality by 50%. Clinically, this is straightforward. Like, he has something, there's treatment for it. But then we have to think systematically. It's not that straightforward. How can he get the help? The barrier is not the diagnosis, because he already got the diagnosis. The barrier is not that there's not treatment, because we have evidence-based treatment. Access is the problem. So when we take things from a system lens, we're seeing that what Legisetti's study was saying, where predicted limited office-based buprenorphine access in rural and lower income areas. There's not that much access. There's provider maldistribution, and the rural areas don't have a lot. Telehealth, if the policy changes that increase telehealth access, he may be able to receive that and have the medication sent to his nearest pharmacy. State-level policies can reshape access for Marcus. At 17, Marcus' barrier would have been higher because he would probably need someone with more expertise, like a child expert. So when we think about all of this, like for our clinicians and trainees, like what evidence-based treatment reduce opioid mortality? What barriers might prevent patients from accessing treatment? How can clinicians reduce stigma in clinical practice? Like, these are the questions I want you to think about. If you were a clinician, if you were a trainee, like a fellow, a resident, if you're a medical student thinking about an interest in addiction, if you're a policymaker or someone in the community, an advocate, I want you to think about this. How do policies shape treatment access? Why might a rural community face greater barriers? Like, what structural reforms could improve access? And ask that policymaker, think about what you're voting for and how that changes. As someone from the general public, think about who you're putting in a place of power, who you're putting in a decision-making place at a population's level, and how that's going to affect you and your community. So let's do a quick crash course about how buprenorphine works. So first, the science. We know that opioid use disorder is a chronic brain condition that involves the dysregulation of the brain's reward, stress, and motivation pathways. Repeated exposure to any opioid actually will alter your receptor activity. So your stress circuitry, your impulse control, all of that changes. And over time, the brain becomes dependent. And it's not just for the euphoria anymore, but now you need it to feel normal, how you used to feel before all of this, and it becomes a cycle. We know buprenorphine is a partial opioid agonist, meaning it activates a receptor that we call the mu-opioid receptor, but only does it partially. It provides enough stimulation to prevent withdrawal and reduce cravings without producing the same level of respiratory depression or euphoria as a full agonist like heroin or fentanyl will. There are a few key pharmacologic features that makes buprenorphine uniquely effective. One is the ceiling effect. After a certain dose, the effect of buprenorphine plateaus. So this significantly lowers the overdose risk compared to a full agonist. It also has a high receptor affinity, meaning it will bind very tightly to that opioid receptor. So this will reduce the reinforcing effects of any illicit misuse of opioids that you may be taking. So you think about classical conditioning. The other unique feature is long duration of action. It actually allows for a once daily dosing in most patients and stabilize the brain chemistry and reduce the craving cycle that you may be going through. Clinically, this will translate to reduce misuse of opioids, reduce overdose risk, improved retention in treatment, improve social and occupational functioning. You stop using or you reduce the using, you're not passing out, you're in treatment, you're going to be hanging out. You have more time to hang out with friends. You have more time to go to work. You have more time to take care of your family. It will improve your social and occupational functioning. The evidence is very strong. We have multiple studies, large-scale studies, that actually show that medications for opioid use reduce all-cause and overdose mortality by more than half. All-cause mortality, so every kind of related cause of mortality by half, by more than 50%. If it works so well, why are overdose rates so high? Access. We're back to. So this is my little call to action. Again, if you are a policymaker listening to me, if you are living in a community member, any kind of stakeholder, trainee, we need your voice. We need more advocacy. Because literally, what we have learned from this episode is medication works. The barrier is the distribution. Access is literally being shaped by regulatory policies, insurance reimbursement, geographic provider availability, pharmacy participation, stigma. There's so many different things that are shaping access to a life-saving treatment. If a county has no prescribers, the medication might as well not exist because it's there, but I can't get it because there's not someone to prescribe it for me. All right, buprenorphine is not just a prescription. It is a mortality risk reduction intervention. We can save people's lives. When access expands, overdose risk declines. Contracts, disparity widens. And unfortunately, it affects people that look like me more. This is the live. It affects them more. Because in addiction medicine, in addiction psychiatry, access is not secondary to treatment. Access is the treatment. And the system is currently feeling like, well, it's always felt like that. It values some lives over others, depending on how much you make, where you live, who you are, where you're from, how much education you have. An intake for opioid use disorder should assess not only a DSM-5 criteria, but what the structural vulnerability is. How far is the nearest pharmacy or provider that could prescribe the medication? Does the patient have reliable transportation? Would daily clinic attendance be feasible? Insurance. Can they afford it? If they can't afford it and they don't have insurance, are they eligible for Medicaid? Is there a case manager or case management in the clinic or somewhere that can assist this person? Have you ever been denied coverage for treatment? Are medication co-pays a barrier? Some pharmacies like GoodRx would have discounts for people. Technology, I can tell you, a patient who got missing appointments and they couldn't come in person because of a medical issue, but they also didn't know how to operate their phone to join the appointment virtually. So like, are there technological problems that are gonna be an issue for the person? How can we get them help? And yes, I understand. If the providers, the physicians start taking on all these other roles, then they're stretched thin doing what they can actually do. But that goes back to the structural system that we're talking about, right? Because the system can be redesigned to include people that can help with that. Example, case management. A case manager can help the patient with transportation, insurance problems, finding the right prescriber, all these things. They can help them with it. Places that have peer advocates, they can support the person going through that with their experience. Do you have reliable internet access for telehealth? Just you realize there are communities in America that have very poor access to internet. There is legal regulatory constraints. Are you currently under a court supervision that restricts medication treatment? that's possible. We just had a forensic and addiction psychiatrist come talk to us about some of these barriers in the carceral system. There's so many different questions that you have to consider when you are treating individuals that misuse the substances. It's so nuanced that you have to take a step back. It can be complex. What are some clinical takeaways from? If you do not screen structural barriers, you risk prescribing a plan the patient can't really realistically execute. That's why we see a lot of our patients go through cycle after cycle after cycle, because whatever treatment plan they received did not really include them. It didn't include their barriers to care. It didn't include what their treatment goals are. Because your treatment goal may be for the person to abstain, and their treatment goal is just to reduce. Like, I still want to drink on special occasions. It's not that I want to stop drinking completely. So you really have to incorporate the person into the treatment plan that you're making and include those structural barriers, at least assess for them. So to close, if you're a clinician, prescribe evidence-based treatment and advocate for access. If you didn't hear me say anything, advocate, 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 advocate. Literally, that's what I have. If you are a trainee, a fellow, a resident, understand addiction also includes structural. It's not just a clinical issue. There's structural parts of it. If you're a policymaker, policy changes directly influence mortality. The decisions you're making is affecting us. If you have a family member, a friend, yourself that needs treatment, go for it. There's help out there for you. Access to treatment, again, is not just a clinical issue. It is a policy decision. And currently, we're not making the best policy decision. We need to do better as the healthcare system for the people that we're caring for. And thank you for joining me today. I appreciate you for coming and listening every second and fourth Tuesdays. And as always, stay ready, stay aware, and stay grounded. Till next time.